Hi, welcome to the online version of this presentation, Patient Journey, Lymphoproliferative Disorders, Old Wine in New Bottles. The live event was hosted on October 4, 2022 by Eastern Great Lakes Pathology, Buffalo, New York, Excel Laboratories of Western New York. We are grateful to our sponsors for providing support to this event, and we are most importantly grateful to all the attendees, a diverse group of audience who included practitioners from internal medicine, medical oncology, um, general surgery, head and neck surgery, thoracic surgery, breast surgery, palliative care, advanced practice providers, and medical technologists from the specialized areas of our labs at Excel Laboratories in Western New York. Before proceeding with the presentation, there are a few comments and disclosures. My journey as a hematopathologist started after graduating in 2006 from a Nebraska Medical Center, and more recently, I took an appointment as a hematopathologist at Eastern Great Lakes Pathology, Buffalo, New York. Prior to moving to Eastern Great Lakes, I served for 3 years in Shared Health Manitoba, Canada. I had this great opportunity to take part in a provincial-wide healthcare reshuffling that was happening in the province, and took on the role of creating systems to enable alignment of diagnostics with the clinical delivery along for complex healthcare issues. Most likely, I mean, you can put it literally like disease specific lines. That was a concept. I also held the position of provincial scientific lead for lymphoma for the whole province. So, and had the opportunity to work with a great team of caregivers and healthcare professionals in the province. It included a great group of hematopathologists within the province. Objectives of this presentation are twofold. I will try to bring my experience in Canada and see how it applies to the healthcare system within the United States as this part two of the presentation. But part one of the presentation, I would like to cover a few aspects of lymphoma classification that are expected to be released in 2022 in the form of a WHO publication, which is WHO publication. So the first part of the presentation is historical perspective of lymphoma and how that transitions into the current guidelines or the anticipated guidelines that are being published. So the WHO classification history is very interesting. The classification of lymphoma existed historically and it was evolving historically. The first attempt the WHO took on was to develop a publication that was very integrated in its outlook to classify hematologic neoplasms. What do we mean by integration? They tried to integrate the clinical information, different aspects of diagnostics, which included genetics, molecular, the bread and butter aspects of diagnostic hematology, which are flow cytometry, immunohistochemistry, put all of that information together, how you synthesize that information to come up with a precise diagnosis that leads to a definitive treatment plan. So that is a mammoth task, and there was some criticism, but I think that is the concept of WHO is a very interesting concept of integration, which is very critical for precision diagnosis and precision medicine. So since then, WHO underwent a lot of additions. We had 2007, 2008 edition, and then there was another edition from 2017, 2018, where there was more and more data that was coming in this field. And the WHO tried to be inclusive of all of that data that was being produced, and tried to fine tune this classification and maintain the concept of integration of diagnoses and integration of diagnoses with clinical management of patients. Now we are expecting the 2022, and um, there was some more fine tuning that is made to this classification, and more of integration from molecular aspects and genetic aspects of disease processes. So, but one of the other things that we're seeing in the up and coming classification is they included the mimickers of neoplastic disorders. There are several disorders that we see in reactive environments, in rheumatologic disorders, that can hugely mimic malignant conditions. They can sometimes behave aggressively like neoplasms would behave. So those were also brought into the classification, and we are hopefully going to be seeing that in print soon. So the current scheme is called WHO HAEM5, and the vision for this particular publication is to facilitate a pragmatic approach to diagnoses. What is the definition of pragmatic? So when we say something is pragmatic, we are dealing with things sensibly, realistically, in a way that is based on practical rather than theoretical consideration. Because what is practical is what we can apply, and what is more tangible, and what it means something for immediate management of patients. What is theoretical is something that pushes the boundaries of science forward. So along those lines, the language that was used that is used in papers in publication to date is that they are looking at the diagnostic aspects as essential criteria, and they are looking at them as desirable criteria. So what is essential criteria? This is the first time that we are beginning to discuss these things, these aspects of essential versus desirable. And it's very important for those of us in practice to understand these things with clarity, because it speaks directly into utilization of laboratory tests, how well we use them, how cost effectively we perform our job in providing the complete healthcare that the patients deserve um, within the health economics environment. So, what are essential criteria? Essential criteria are defined as minimal criteria to allow the diagnosis of an entity as universally as possible. This does not translate into rationing of healthcare. This essentially says that we have to apply all the tools that are absolutely needed to establish a precise diagnosis so that the patient can take advantage of the current treatment modalities and standard of care treatment that's available to them in the existing environment. The desirable criteria are those that aid in confirmation and refinement of the diagnoses. So, what do we mean by that? Which means that in certain circumstances, we need to push the boundaries. Usually happens in tertiary care environments where clinical trials are operational, and you need to push these boundaries, and you need to apply new modalities of care in patients where all avenues are failing, or we want to give some added advantage to patient management. So we tweak the diagnoses, or we tweak the management of the patients. The patients are enrolled into different stages of clinical trials, and it's a totally different environment. So in real practice, in real time, we have to make ourselves familiar with the essential criteria that are absolutely required to conduct the kind of healthcare that is required for the patients. So it is important to note that in circumstances where resources are not available, not everybody is a patient in the United States or in Europe. There are patients all over the world, and the physicians who are catering to these patients, catering to the healthcare of these patients, providing healthcare, refer to these WHO publications. So we have to make an attempt as to how to bridge that gap for resources. Many of these places are under resourced, and they don't have the ability to perform all, they're not perform all the kind of tests that we take for granted in North America or in Europe. So, how do we make it possible for people living in these parts of the world? So, that is one of the aims. The second thing is also to address disruptive science and technology. What does that mean? The science and technology tends to affect different segments of specialties in different ways, different parts of healthcare in different ways. For example, in the surgical field, we moved on into minimally invasive surgery. And once we apply minimally invasive surgery, the amount of tissue that comes out of minimally invasive surgery may not be the same as the amount of tissue or the volume of tissue that comes out of an open procedure, which means that the pathologists have to adapt themselves to changes that are happening in the surgical area. But most importantly, it's not about adapting ourselves to these changes. We have to align ourselves and align our recommendations to what we provide to our surgical colleagues, to our counterparts who are providing this valuable diagnostic material, so that collaboratively we are moving towards a decisive diagnosis, which means that we are not looking at these systems as a handicap um, in um, in in achieving quality material that is required to provide decisive diagnoses. So suboptimal quality and quantity of material seem to be a practical aspect that are affecting the pathology community on the whole, and some of these aspects also need to be addressed as we move forward, as science and technology is racing ahead and the demands on diagnoses are racing ahead. So these things, some of these problems may not be that much of a problem in other parts of the world, but this is my opinion only, mind you, having been in practice. I wonder if this is uniquely a North American problem because of the lack of balance between different areas where the technology is advancing, and lack of alignment creates lack of understanding of what is needed in pathology and what is provided to pathology for success in preclinical areas. So we are going to discuss some of those, and as one of the disclaimers I do have to make is, as we talk through this presentation, there may be a lot of opinions, but there's very little data. There's only experience that tells, what we are actually facing on the ground with some of these concepts. So, highlights for this presentation, I'm only going to talk about two most frequently encountered categories in lymphoma. I'm not going to cover the entire lymphoma classification. The first one we would cover is large B-cell lymphomas, and we are going to show you what happened in the past and where are we moving in terms of classification into the future. The most recent publication is WHO Heme 4R, and the up-and-coming classification is WHO Heme 5. In the WHO Heme 4R, there is a certain way we classify the tumors. We call primary diffuse large B-cell lymphoma of the CNS. But now we are taking that and we are regrouping it based on the etiology of these things. So it's rebinning of this data based on the etiology and based on the biology. So if there is a CNS lymphoma and it's associated with immune deficiency or deregulation, then it's going to be called immune deficiency or deregulation associated lymphoma in the CNS. And we have to be performing additional tests that most often end up being positive or could be positive in this setting. So each of these classifications are actually the diagnostic tools that we need to use, or the diagnostic testing platforms that need to be applied are embedded in the center portion of this diagram that you can see. So essentially you're seeing in the center portion what we need to apply and what is needed in order to move into that precise classification scheme. So what essentially is needed is an adequate biopsy. So as pathologists, we need to define what adequacy criteria are to achieve the diagnostic success, and what are the tools that we use. The first place, always we start with morphology. We look at what we are dealing with under the microscope, and it gives us enough information to apply the correct testing platforms in the context of morphology and in the context of clinical presentation. So both these aspects are very critical for us to have that clinical information about the patient, and about the biopsy, and what circumstances this is being performed. And morphology leads to immunohistochemistry. They are inseparable twins. So immunohistochemistry algorithms are important in providing that diagnostic and prognostic information and classification scheme for lymphomas. We apply and interrogate for EBV where it is applicable. And we also have to perform FISH studies, fluorescent in situ hybridization, in certain settings to interrogate for a few, looking at a few genes that are involved in the classification of these lymphomas. So on this slide, you see in the center aspect of the slide, you see the genetic changes. We are starting with morphology. In case of large B-cell lymphoma, we have this impression that we are dealing with a high-grade B-cell malignancy. We apply immunohistochemistry, and it gives us the classification scheme based on immunohistochemistry profile. Then we are moving and applying certain probes, and we are using fluorescent in situ hybridization to interrogate three genes, that is c-Myc and BCL2 and BCL6 genes. The pattern of translocation of these genes allows for us to classification and reach a diagnosis of either a diffuse large B-cell lymphoma or any of these aggressive high-grade B-cell lymphomas. It's important to distinguish and identify these aggressive high-grade B-cell lymphomas within the category of large B-cell lymphoma. Large B-cell lymphoma in itself is aggressive, and it is treated with a curative intent. But within this category, based on the molecular classification, there is a subset of lymphomas that are even more aggressive, and they need to be identified at ground zero so that we are able to apply precise treatment to achieve success in these patients carrying this diagnosis. So the second disease entity within the category of lymphomas is follicular lymphoma, one of the most common lymphomas that we encounter. And it can be low grade, it can be high grade. So it's important for us to distinguish that. So what WHO is telling us is to retain the classification scheme that previously existed. So the old classification is here to stay. So, and that classification is made using morphology, and it is made by evaluating the frequency of large cells in neoplastic follicles. So the large cells are called centroblasts. In the lower grade, we see fewer centroblasts in the follicles, and for the counting of the centroblasts, and all those guidelines are given in the WHO publications, and one can refer to those. The higher grade are obviously graded because there's an increased frequency of these large cells called centroblasts. Now, within the higher grade, the 3A and 3B, a distinction needs to be made, and that is critical, and that's now established moving forward. So grade 3B is equivalent to diffuse large B-cell lymphoma in its behavior and treatment approaches, while grade 3A is not so much. So now this distinction has to be made within this category. And moving into a slightly higher layer of complexity, as pathologists, are we able to make this distinction very easily, very clearly on every single case that hits the door? The answer is not really, because there's always ambiguity in medical oncology, and there's always an ambiguity in diagnostic hematopathology. So the ambiguity, as you can see in this picture, is sitting right in the middle. The two poles to this are areas where the diagnosis is slightly easier to make. which is follicular lymphoma grade 3A, and if it's follicular lymphoma grade 3B, we should be able to recognize this as experts practicing in hematopathology. The one that can be a challenge is the one with ambiguous morphology. In those instances, there are some clues or pathways that are being provided to practicing hematopathologists based on the molecular profile as well as the expression of CD10. So if BCL2 gene is translocated and if CD10 is positive, then it is moving in the direction of follicular lymphoma grade 3A. And in this category, we do know that diffuse areas are uncommon and bone marrow is frequently involved, and CD10 is positive, BCL6 is positive, BCL2 is positive. This is protein expression on the neoplastic cells as demonstrated by immunohistochemistry. And they are negative for MUM1 protein expression. And as I said, the BCL2 rearrangement is common, the 1418 translocation. So on the right side, you're moving towards follicular, what is to be expected for follicular lymphoma grade 3B. They are negative for CD10. They tend to be negative for BCL2 rearrangement. Diffuse areas are more common, and bone marrow is infrequently involved in this case. And they can express BCL2, or they can be negative, or they can be positive for MUM1, or they can be negative. And they can be rearranged for their BCL6 gene, and they can be MYC rearranged. So these are some of the tools or some of the thought processes that may allow us to move in one direction or the other and take it to as precise diagnosis as we are able. But most importantly, it is necessary for us to be able to sample these lesions adequately so that we are able to make that call and we are not stuck in limbo because there is inadequate material and we are trying to push a diagnosis one way or the other on suboptimal material. So that is how we bring in those definitions that I previously described into our daily lives and what it means to us and what we need to be discussing with our clinical colleagues if the intent is to establish hybrid standard operative protocols that all of us agree on in the preclinical setting. So highlights of follicular lymphoma are the nodal follicular lymphoma negative for BCL2 rearrangements is a challenge. It's heterogeneous, both genetically and clinically. The specific subtype tends to be CD23 positive, which is a marker that we perform by immunohistochemistry on tissue. And it can also stain follicular dendritic cells. The B cells tend to be positive in this instance. And it's proposed as a provisional entity. And it tends to carry mutations. If you do next-gen profiling, next-generation molecular profiling testing, you can see STAT6 mutation. And it tends to have a low-stage disease. It can have a diffuse growth pattern, and it usually presents localized to the inguinal region. So it's a low-stage disease, can have a diffuse growth pattern. It has a certain type of molecular profile. Right now it's a provisional entity, and since it is localized, are we going to be, evaluating and handling these patients a little bit differently will be a question for us to understand prospectively. So in these circumstances, the desirable tests may come into place because these are a small subset of follicular lymphomas we tend to see. And if we put all of this information together, the clinical information, the staging information, and then it becomes important as we are interrogating these patients to use additional tests. We are not doing this on every single patient walking in through the door, but we are restricting this kind of testing to a cohort of patients within the category of follicular lymphoma. That is appropriate utilization of desirable testing in the field of follicular lymphoma. So I'm hoping that these two examples give you a snapshot of thinking along the lines of appropriate utilization of diagnostic tests. There are so many testing platforms and so much information that can be gleaned across these platforms. But when do we apply them? How do we apply them? and how do we make this entire diagnostic process patient-centric and comprehensive, and we stop applying everything under the stars to every single disease entity, which is not really a cost-effective approach. It's triaging. And so that's a concept that probably we need to think more and more as we move forward, as the science is advancing. This is reference for the two publications that are that have so far discussed the up and coming proposals with WHO. Now, moving to part two, this is perhaps the thought generating part of this program, and requires for all of us to see how we have been practicing and how we need to be practicing moving forward. So, the patient journey. The patient journey is an interesting concept. And we will try to describe that, and we will also try to describe where diagnosis falls within the concept of patient journey. The patient journey is from when the patient first is in contact with the healthcare system seeking healthcare. Then there is continuity of care. If as the patient needs are become more complex, there are different areas of medical science involved, and they constantly need to be interacting with each other, providing continuity of care so that the science doesn't fall through the cracks and the patients don't fall through the cracks along with the science. So can we establish those systems? And do pathologists have a role in providing support to this decision-making process and making things seamless? So these are some of the concepts we will be discussing. And why and how of healthcare delivery? Why should we be worried about this? We can come to work, go about a business, but should we gain additional knowledge to understand what role each of us are playing in the big picture? So we'll try to some of those points. So what are the nuts and bolts of building diagnostic algorithms? So, and where do they come into play most often? So again, I'm going to revert back to this concept of essential and desirable in the tools and how we use them. So essential is to achieve appropriate utilization of lab tests or clinical concepts of care, we need to have standard operating protocols. And those are important so that we decrease the variability in the preclinical setting, which means that, for example, a quick example is that when there's a provider like intervention radiology or surgery providing us a tissue sample, there could be a huge variability of how much tissue can be obtained, the quality of the tissue, the sampling of the tumor itself. There could be a lot of variability. And that variability can happen because of the operator, or that variability can happen because the systems are not in place, where there's a cohesive functionality between what is expected by pathology to make a diagnosis and what is being provided by the clinical systems in place, by the operators. So the standard operating protocols that are built collaboratively have a way of handling those issues where all of us function as a team and we understand each other and we develop systems that meet each of our needs, thereby we are meeting the needs of the patient. So that is a responsibility of a collaboration between the clinical systems and the diagnostic systems in pathology. The second bulleted point is specimen handling. Specimen handling begins from the time the biopsy is taken out of the patient to the point of involving transport to the specific laboratory, whether it's within the institution, across the institutions. A number of things come into place. So that is also a responsibility of functionality of alignment between clinical and pathology. The third bulleted point is choice of testing platforms. So this is something that is done very well in some provinces in Canada, and Manitoba was one of them, where they established these even before I went there, and they're getting better and better. if they're able to sustain it, I think that's a very nice way to approach diagnostics. The choice of testing platform, pathologists are the practitioners, or pathology is a practice that has a very good hold on what type of testing needs to be applied. And by saying that, I do not mean to say that our clinical colleagues um, have gaps in understanding what testing algorithms to apply. Both of us are trained to do so in the clinical area as well as in the pathology area. But the specifics of each test, pathologists, that is the area of pathologists, that's the specialty of pathologists, the quality, the quantity, what can be applied, what is the result output, can you believe that result, can you not believe that result, is it a false positive, is it a false negative? All of these are sitting in the area of pathology. And so it becomes important that pathologists play a very proactive role in picking the right tests. Especially, it makes the most sense because by looking at morphology, you already know what you're dealing with. And with that knowledge in place, you're able to pick the test that makes the most sense. You're not picking 3 tests where you should be picking 1 test. So that is called choice of testing in pathology, and accurate testing of pathology. But it's not such an easy process. It's quite complex because some of these tests need to be done on fresh tissue. And the process of transportation, the tissue may not be fresh. So you need to apply some tests ahead of time, even though you need it or not. So the dynamics of applying the right test is very complex. Having said that, again, pathologists have the ability to provide useful information and guidance in what kind of testing platform can be appropriately applied and utilized. Especially this becomes important when we are dealing with complex testing platforms such as morphology, immunohistochemistry, and as we are moving down that list of tasks, it becomes more and more expensive. So we need to keep that in mind. And pathology report, once we produce a pathology report, as most of us know in this audience, the reports are very complex. They're several pages long. So how is a pathology report constructed? And is the information in the pathology report, is it easy to comprehend? Is it easy to understand? Is it easy to apply? And so that is a field that is also being looked at very actively, especially by College of American Pathologists, in order to make things more user-friendly. It's very important to do that because once the pathology report is produced, it is read by diverse group of audience. When I say audience, I mean to say specialists on the medical field. So at different levels of practice. So how can we make that more user-friendly and applicable? The next thing is there's always a role of consultation. And this is very critical. Communication and consultation are very critical. So what do I mean by that? Is that once you produce a pathology report, the information and the data that is being disseminated is so complex that it may be just easy to pick up the phone and call a pathologist, produce a report, and discuss the case with them post-production. And that might lead to make things easier. And also take away any ambiguity that is associated within the reports. So these are all the concepts, and are each of these things, when we look at the organization, and if we look at systems-based practice, are each of these bulleted points mutually exclusive of each other, or do they need to be in sync with each other to produce a system in place that protects the practitioners, that protects the pathologists, and that most importantly protects the patients? Because when they're all working in sync with each other, you produce a very good product at the end of the road. So that is the concept of essentials in providing the kind of care we want to move towards. So, and all of this, we should never lose sight of the clinical information and the clinical presentation of what began us interrogating the patient using all of these steps. Now, the desirable thing is, let's just say the patients are progressing, they're being treated using all standard of care modalities, and there's refractory disease. We are moving into the world of clinical trials. So it is in that setting that we apply esoteric tests. We apply tests that are not a part of bread and butter practice, but we are applying all these additional tests, and we are trying to figure out which way to go, how we can, help the patients further, how we can push the boundaries of science. So that is the desirable area. And usually this aspect of care is present in a few tertiary care centers. And access to those facilities is, for patients, is a different aspect of healthcare. So tertiary cares usually handle high acuity care, clinical care, and clinical trials, and diagnostic reports and platforms are more in alignment with the kind of care that they provide in that setting. So essential care. So ahead, where should diagnostics sit in the big picture? So for oncology, these patterns have been studied for many years now, and this is a roadmap of how you align the system so that you see the most success out of it. So on this side, what you're seeing is, in the beginning, the patient has a problem and they are interfacing with the healthcare ecosystem. And when we talk about diagnostics, generally we think about pathology and imaging as diagnostics, or in some places, intervention radiology is also considered as diagnostics. But there are several aspects in clinical care that are also part of diagnostics. So it's entirely the diagnostics ecosystem, which consists of patient interfacing, the first step, patient's interface with the healthcare, the clinical colleagues who are seeing the patient in an outpatient or in inpatient are assessing the patient for the problem. But this problem recognition is happening at 30,000 feet up. There is huge differential diagnoses. And sometimes the differential diagnosis can be pretty narrow because it is very telling what the patient is going through. And based on that, the diagnostic aspects come immediately on the heels of that. So tests are ordered, either clinical laboratory tests are ordered or tissue-based tests are ordered. And then a diagnosis is performed as a next step. The information out of these diagnostic tests is integrated, and then it is passed on into the implementation area, which is on the right side after post-diagnostic implementation area. And that is the interface between the diagnostic and clinical areas of implementation, where there's some consultative role for pathologists in place. If all of these things are done well, we have the ability to produce accurate diagnoses, timely diagnoses, and also reduce diagnostic errors, and improve patient outcomes and improve system outcomes. And the lean system also can be very cost effective. And it also creates another environment for us. It's a learning environment, because nothing is foolproof, and we are in a very high risk environment. So if there are hits and misses, we need to constantly educate ourselves about what is missed, what can be done better. So harnessing data from deviations in care or missed opportunities is going to provide a feedback, positive loop into the system, so we can constantly improve on what we are doing. So that is the nuts and bolts of healthcare delivery, that is very patient-centric, and where the diagnostic process for malignancies is upfront in the process, where the patient is actually engaging the healthcare system, and it's not a tail end of the process where the patient is actually traveling through the healthcare system and reaches a tertiary care center, and all the diagnostic testing is repeated all over again in a patient who has probably encountered delays in treatment and advances and the disease is advanced. So that would be an imperfect system. So it's of great value if the diagnostics is happening upfront. And now let's make a case. This is another way that explains where the diagnostics needs to be placed in the scope of patient journey as the patients are traveling through the different parts of the healthcare ecosystem. So what you see on the x-axis is on the top is a patient is traveling. The prevention is happening early on and it's in a community care setting. Immediately after prevention comes diagnostics, either it is screening or making a definitive diagnosis with an intent to treat. Part of palliation comes into that as well. And then you have follow-up, survivorship, all of this, and end-of-life decisions. And as you go up along the y-axis, you see again at the bottom of the y-axis, you're seeing vaccinations, preventive care, all of this is sitting in the y-axis. And if the patient needs to reach to the second layer of treatment, there are secondary and tertiary care centers where we have the hospital systems. And these hospital systems are engaged in providing the diagnosis again upfront. Any procedure that is done to the patient at this time is within the compartment of being able to make the diagnosis, giving it a name. And once we know what we're dealing with, then you move on to giving definitive treatment to these patients and applying, radiation oncology comes here or chemotherapy comes here. So all of these, the patient is moving up the food chain. That's basically how it happens. So these have been studied, and I have references for these mechanisms in publication and provided to you. And so now coming back to diagnoses. So we said pathology has to be upfront in malignancies. So what do we mean by upfront? In my mind, I kept thinking, and of course, working in Canada gave me this belief, essentially that the pathology has to be where most of the patients are sitting because it's early in the process, and majority of our patients are sitting in the community. And the bulk of our cancer patients are sitting in the community. They engage the healthcare system sitting in the community. So the diagnostics and high performing diagnostic is the value for high performing diagnostics. To me, I think there is huge value to bump up the quality of diagnostics within the community setting because you're directly in facing with majority of the people sitting in that community, and there is a need for that. So in a value-based healthcare model, so upfront diagnostics has a huge value, and its value lies in creating relationship with this multidisciplinary group of physicians who we serve, and exchange of information that is real time. In the context of patient care, you know your patients as well as your clinical counterparts know their patients, the clinical colleagues know their patients, and you're putting all of this in a multidisciplinary pattern and you're giving the whole package. So that is where the value lies. And a high performing lab, what does that do sitting in the community? The fundamental decision that we make is dividing between, is this a malignant problem or is it a non-malignant disease process? Once you make the decision, the patients start to move along different lines of care. So if it's malignant, you have to establish that essential diagnosis, which we discussed about. And the essential diagnoses, the diseases are neoplastic, there may be chronic problems, can be easily managed closer to home within the community in an outpatient setting, or they can be high acuity problems, which may be a little bit difficult to manage within the community because there are no systems to take care of that complexity of healthcare. So the patients get referred out to these tertiary care facilities. So there is that marriage in the system that you can establish to move the patients, even in settings like United States or even in Western New York. So the value for high performing diagnosis in the community and essential care is upfront comprehensive diagnosis is critical to patient journey and diagnostic journey, because there is great value in arming yourself with information that is critical for patient management upfront. You exactly know what you're dealing with and prevent repeat procedures and delays. If you don't know what you're dealing with, you end up doing more tests, unnecessary tests, repeating the same thing, expecting a different result. Most of us in practice know all of this. So this is what happens. And is there, if we put value in these systems, is that going to help us achieve these goals? Once the patient is non-malignant, it could be either infectious disease, it can be an acute other chronic process or other process trauma. There are many things that are non-malignant that are equally important. And autoimmune problems. So coming back into lymphoma, there is that fine continuum between autoimmune diseases and lymphomas, because lymphomas are diseases of the immune system. Hematologic malignancies are diseases of the immune system. So we need to have a continuity of care and crosstalk between these two aspects of the disease line, autoimmune versus lymphoma, where patients don't fall through the cracks, where autoimmune sits in the non-malignant side and the lymphoma sits on the malignant side. So high performing diagnosis in the community, who benefits from having this? We talked about the value. Now we are going to talk about people benefiting from that. So there are three people. You're looking at the payers, you're looking at the patients, and you're looking at the providers. Is it a win-win situation? So if we define the who benefits, prevent repeat procedures, who benefits from that? Patients benefit from that, less traumatic. Physicians benefit from that. They don't have to keep redoing the same process, expect a different result, or they are so laser sharp, focused, working within these systems that are very focused on outcomes, and they're very productive for patients. And obviously, by not repeating the procedures, you're making it very cost effective. So the payers benefit from that. The lean diagnostic algorithms, the payers, patients, physicians benefit. You can see improved turnaround times from first contact. We are not talking about turnaround times within diagnostics. Turnaround time has to be a concept from first contact to decisive treatment. So payers benefit, patients benefit, physicians benefit. Streamlined access to healthcare delivery. All three people benefit. Triage between essential and desirable. Definitely it has a huge impact on health economics, and payers definitely benefit from that. And continuity of care, the patients benefit from continuity of care. Current state of healthcare, what do we have post COVID? What are the opportunities and threats? So if we want to establish systems like that, did COVID make a dent in the system? Was it a wake-up call? Is it providing opportunities to us, and what threats are we facing? So it's like a three-legged stool. Health economics and payers are still sitting on the top because money is not endless, and usually resources are defined, are financial. And the three legs of the stool are scientific evidence, clinical diagnostic expertise, and patient expertise and values. So we look at scientific evidence. The opportunities are precision diagnosis and treatment, evolving science, evolving technology. The threat is from that comes knowledge gaps. So most of the people involved in healthcare, do they know everything about everything that's happening around us? Knowledge gaps. And implementation is another whole different beast. So these are the threats for that leg. And there may be many others, but this is basically what came into my mind. And I put them on the slide. So clinical diagnostic expertise, it's a known fact that you need to have experience, you need to have critical thinking in delivering the care that is needed, and everything is not automated. So opportunities are again precision diagnosis and treatment, and threats are attrition of healthcare personnel. Counting heads, we are losing people. Experience is walking out of the door. And are we able to create a legacy system in place that is, you know, transporting or transferring this knowledge from one generation to the other? Are we doing that effectively? Huge gaps in the system, huge gaps in the knowledge, huge gaps in knowledge gaps as well, and critical thinking versus automation. So, how much ever we automate, there's always a component of critical thinking: when to apply, how to apply, and experience that comes from gaining this knowledge um, is huge. So when we erode into that, we are losing the knowledge walking out of the door. The third leg of the tool is patient experience and values. So who defines what patient experience is? Who defines what patients value? Those definitions are being studied in the healthcare system hugely now. And maybe at some point we're going to understand what patients value. Do they value cost savings as they go and try to get themselves treated of a disease process they have, so that they are not going into bankruptcy trying to get better? Is a healthcare system making them feel safe? Do they go to a hospital system, or when they're engaging their physicians, do they feel confident? Do they feel safe that they're getting the care that they want so that they can get better and get on with their lives? And how are patients defining quality? What does quality mean to them, to the patient? What does the quality mean to their family? What does the quality mean to community? The sooner we are able to get people back into workforce, it affects the community, it affects the ecosystem in the community. So are we looking at all these aspects? So these are the definitions, and that is basically controlled by cost, by resource allocation. So, and the resources are largely in the hands of insurance, pharmaceuticals, and government, controlling, how the resources are allocated. And resource allocation is usually financial. And the resource allocation also creates competition amongst people and healthcare providers providing the healthcare to the patients. So, where is value in all of this? So, who's defining, who's assigning the value, who's defining the value, and who's allocating these resources in a complex healthcare environment? So, again, we go back, take a few steps back, and you look at the entire healthcare system. There is healthcare happening in community for majority of the people, and healthcare happening in tertiary care centers that are able to provide to a small cohort of patients with complex problems. So in the community, you have community diagnostics, prevention and screening, chronic disease, oncology. All of this is happening in the community, and it's happening in a privatized system of healthcare in the United States. And on the right side, you have specialized, which is also largely privatized system of healthcare or non-for-profit organizations. And you're looking at cancer care centers, large centralized labs across the United States, where you can FedEx your samples, send them away, they'll put out a report, and that's how the process works. With a lot of gaps in that system, and innovation and clinical trials. So that's the huge division and two compartments of healthcare. So, but majority of the patients are sitting in the community, and community is taking care of 80%. If you look at an 80-20 rule, 80% of the patients are sitting in the community, and that is where they're getting their healthcare from. So resources, are the resource allocation proportional to the distribution of the patients where they're sitting? Unfortunately, the resource allocation is polarized more towards the specialized areas where, either it's pharma or it's technology. We are trying to push the boundaries of science, and the return of value is seen in developing a new technology as a business investment, or developing a new drug. There's a huge return of investment, and a lot of the resources are allocated in that direction. But are those new technologies, are they able to penetrate the market? That's another business question one can ask if you're looking at healthcare as a business. So because majority of the people who utilize these technologies are sitting in the community, is it actually transferring from where these innovations are happening effectively into the community area? Are we training enough personnel? Are we upping the game within the community in order to penetrate this technology and advancements in therapy to people who need it the most, who are sitting in the community? Are we engaging our patients effectively? So we look at these models. It's very common sense tells us that it's not a binary choice. You have to find a fine balance in how we allocate our resources between both our tertiary care environments as well as community care environments. And there is a huge need to improve on how the healthcare delivery happens in a community setting. In allocating, in terms of resource allocation, there are people there doing the job, but how are we supporting those systems and community is a different question. So there needs to be. So when we look at that, we discussed competing groups, peoples, and programs. Um, and their environment in United States creates that competition, and the competition is supposed to improve on how we do our jobs. But is it also creating a vicious cycle? And lack of systems in place, do they create a vicious cycle in which the patients are caught up in this loop because we don't have appropriate systems, or we don't have appropriate standard operating protocols that are harmonized well to provide that healthcare delivery? So, and is that affecting continuity of care? Definitely, the continuity of care is affected most often. So, how is that? This was a diagram that I created back in Canada when I was involved in shared health, and just to make it more easy for people to see how the patients travel through the system. So on the top, the patient is sitting, and the patient seeking healthcare itself may be delayed. This is called social determinants of healthcare. Because of where they are, they may not want to get healthcare. So there are many aspects which are beyond the control of hospitals. But once they seek healthcare in the doctor's offices, there is a huge variability in how the patients are handled, and that leads to delays. The patients can say watch and wait, or I'm going to act on it immediately, and that might be a swing in either direction: overutilization, underutilization, delays in system. So there is an opportunity to harmonize things in that and prevent those delays. But once a decision is made, the procedure that is chosen in order to obtain diagnostic material and the choice of testing may not be the most appropriate one. There may be gaps in that system, and that choice of wrong testing can create gaps in the system, and it's not adding any more value. And once it hits the pathology labs, the way the labs are set up in providing diagnostic services may not be aligned appropriately for the clinical services and the questions asked, which creates delays. And so all of these delays tend to be exponential, and they add to a decreased quality in healthcare, but they also add to the cost of healthcare delivery. So if we can break that cycle, and if this cycle is allowed to perpetuate, what generally happens is the patients end up in an emergency. Imagine a patient who could be treated as a routine patient, as an elective patient, ends up in an emergency. That's more expensive from the get-go. They end up in an ICU, and ICU is more expensive, and they are subjected to emergency procedures for diagnosis, which is much more expensive. So what we are doing is a patient who could be traveling on a passenger train, you put them on a bullet train. So there's very expensive protocols on both sides. So by fixing the systems, are we able to fix some of these problems? So alternatively, what we can do is to provide tools to the providers, which is called decision-making tools to the clinical providers. So what we do is the tools that are required in the primary care setting is to come up with checklists, come up with systems in place where the practitioners know who to reach out to, who to ask for questions, if there are questions, how to recognize things, and support that decision-making process in that setting. And if the choice of complex tests is coming into place, are they given enough tools to make those decisions? So, and once the right testing is done, or right choices are made, so that is a marriage between the primary caregivers and specialists. Are we able to establish systems to that effect? And the right testing is done, and handling of specimens within the labs is done accordingly, and we are preventing diagnostic pitfalls, and our quality systems are geared along disease specific lines and integrated disease systems. So it's not like one disease specific line does not talk to the other disease. They're all integrated complex systems. Once we create that, are we able to give timely diagnoses and timely care, and we are able to move that stress on the emergency management of patients, because we did not take care of the patients in a manner that can be routinely taken care of. So now that's a concept, and I would like to bring a little bit of my Manitoba experience into this, from concept to implementation. We can't fix it all. So there was a little bit low hanging fruit was a lymphoma service, which was immediately within my portfolio as a clinical lead of the service as well. And it's important to look at the map of any region that you're involved in. And Manitoba is a large province, and the geography is very variable, and the distribution of people within this province is also very variable. So how do we address that? And we have to serve all the people in all of the communities and be able to provide that healthcare. And so take all of these, and you also see the distribution of the hospitals, distribution of labs, distribution of satellite labs, point of care labs. So all of this comes into picture. So one of the things, protocols we created, so that's the hugely big picture. So we started in small packages and small increments. The first thing that I was involved immediately was interfacing with intervention radiologists in the preclinical area and the head and neck surgeons. In head and neck, this is a snapshot of what kind of lesions that you can see in the head and neck area. And the reason we are talking about head and neck is that it's a very complex space. It's a very narrow, tight space, and the need for head and neck surgeons, their needs are very specific. They want to know what they are dealing with the least invasive process that is possible. So pathologists are we able to provide them with that information, with that kind of information? So no matter what the condition is, again, any procedure that we adopt will have its strengths and weaknesses, but you want to create a system that works most often, most of the time, produces good results most of the time. So knowing what is involved in head and neck and what might be the huge differential diagnosis, the clinical examination of the patient pretty much tells you what you're dealing with. It narrows down the differential diagnosis, the age, the presentation, the clinical picture, all of those taking into consideration. The test that the head and neck surgeons like to apply or subscribe to is fine needle aspiration. And there we aspirate the lesion. We get some cells. It's not tissue. And a good aspirate will give us good morphology. We can prep the sample and we can look at it under the microscope. And it is able to tell us whether we are dealing with a hematologic process or a non-hematologic process. So I'm going to move to the next slide. There's a lot of information on this slide about FNA, the false positive, false negatives, and how we move through the process. So what we did was, that is what we did. We created a collaborative framework for diagnostics between the cytopathologist and the hematopathologist, where the specimens all go to cytopathologists, they look at it, they know immediately from the get-go whether they're dealing with a lymphoid predominant lesion or hematopoietic predominant lesion versus they are dealing with something that is not a hematologic process. And in order to achieve this, what we did was we took away the redundancy. So applying flow cytometry to fine needle aspiration was a redundancy. It added time, it added effort, it added resources that did not add much value to the diagnostic process. It actually delayed the process. So by taking away the flow cytometry, just looking at the morphology and building that bridge of collaboration between cytopathologists and hematopathologists, we are able to produce a joint report. In that joint report, we are able to conclude, say, whether it's a hematopathology related disease process or a non-hematopathology related process. So once we say it's a hematopathology process, it goes down the pathway of medical oncology. So once we need to get a tissue diagnosis, and the head and neck surgeons now have the confidence from that report that is produced from FNA saying that this is hematologic, we need tissue, they go ahead and give us tissue, they incise. And if they know that they are dealing with a non-hematology like a melanoma, sarcoma, carcinoma, most of them are squamous cell carcinomas in the head and neck region, and they know what they're dealing with from that FNA procedure, they're dealing with the patient, their treatment protocols are completely different from that. So the heme aspect is completely scored out from the equation. It gets eliminated. So it's a paradigm shift in our thought process. We are not looking at fine needle aspiration as a procedure, and what tests do we need to pile on, and piling on more and more tests on that kind of a test that has a certain bandwidth. Is that really of value, or are we moving the patient through the system by providing what is of immediate value conclusively to our clinical colleagues so that they can act on it to take the patient to the next stage? So essentially what we did was we said, you're dealing with the heme process, patient is treated like medical oncology, gets a tissue biopsy. It's a biopsy procedure, we make a diagnosis, and a lot of these times, all of that resulted in a lymphoma in these patients, and conclusively so. And we decrease the turnaround times rapidly to, from end to end, we decrease it to the point of diagnosis of 2 weeks. Now we move into the other direction. We conclusively excluded a hematologic process. We're dealing with something that's non-hematologic. Different questions are asked. We move the patients along that journey. We did not add on anything. So there was utilization built in, decrease in delays in patient transit time, and definitive diagnosis was rendered as a screening tool. So we used it as a screening tool. So this is a multidisciplinary approach for diagnosis success. And the idea is to minimize the risk to non-heme patients. So it's a sandwich protocol. This is what we call. It's a win-win situation between the needs of head and neck disease category and lymphoma. Lymphoma needs tissue, head and neck needs to be minimally invasive in the beginning. So we were able to achieve that and give the head and neck surgeons the confidence to proceed to an invasive procedure like a tissue biopsy, because they are armed with the knowledge that they are dealing with a hematologic malignancy. There's no doubt in their mind. And that was the success story from that entire exercise. So this is again giving some more information about the process that we created. And that brings up to an entity called Choosing Wisely. Choosing Wisely is an initiative that has been around for some time now, and it speaks to the same concepts that we discussed about supported by evidence, not duplicative of other tests or procedures already received, free from harm, and truly necessary essential diagnosis services. So now, because I'm a hematopathologist, I wanted to highlight that American Society of Hematology participates in the Choosing Wisely program. And in Canada, Choosing Wisely is all over the place because utilization and is an extremely important goal for Health Canada. So the second bullet over here is going to give you information. You can go into choosingwisely.org, and it gives you a list of participating organization. You think of it, every single subspecialty and specialty practice is having links to Choosing Wisely initiative. So it's something that would be interesting for us to read up and see what we can as individual practitioners do to facilitate these kind of changes. One of us have a role to play. So can we influence how we are initiating these and implementing these changes, and making things more precise? So when we look at these healthcare models, clearly we are in the area of business in healthcare, and we are talking about corporate healthcare models and corporate hospitals. And most importantly, in post-COVID, everything is undergoing reorganization around us. So how do we survive the system? And knowing where we are in this system is very critical for us as practitioners, as healthcare providers, and where are the patients in all of this. So in this totem pole, I will leave it to all of you and your own thoughts to figure out where in the totem pole the patients sit, and where in the totem pole do we as practitioners of healthcare and healthcare providers sit in this totem pole, as and are we engaging effectively with the entire organizational changes that are happening around us? Are we engaging, or are we given the opportunity to engage so that we are able to develop systems effectively? So these are some questions. I will leave them to you to ponder on as a part. So final thoughts, processing all of this information. What value does pathology give? Pathology gives an important value in pathology supported decision making. It's a new layer of value, and seamless patient management pathways are diagnostic and clinical. They are not clinical pathways alone. If we do not incorporate and align diagnostics with clinical pathways, we become two parallel lines. And what we are seeing is resourcing of diagnostic criteria pushed to the fringes. So, and that can cause more harm than good for patient care. And the third point is multidisciplinary models of care and minimizing variability. So, harmonizing, creating standard operating protocols across different specialties, integrating them together, maintaining a continuum of how the patient walks through a disease process. These are very critical in patient management. And we try to bring this into our own labs and Eastern Great Lakes Pathology and Excel labs. So our mission statement essentially is focused on quality, process, and outcomes. The process is very important. Engaging our patient colleagues, engaging our clinical colleagues, and thereby engaging our patients. It's very critical, and very critical to provide that real-time support to different specialists, different practitioners within the community is very critical mission statement for our practice. So this is basically what we do: diagnostic decision support embedded into our practice model. With this, I'm going to stop and thank you. And I would like to take any feedback that you might have in the way of comments and ideas after listening to this lengthy presentation. Thank you for your attention.